We'll turn off the recording for the rest of the session. So today we are covering Tennessee Community Overdose Response Education, also known as Tennessee Core. And our speaker today is Dr. Bill Brooks, who is an assistant professor at East Tennessee State University, whose work focuses on harm reduction, overdose prevention, and community-based overdose response training in Tennessee and the Southern Appalachia. Next slide. Okay, Dr. Brooks, I'm going to give it to you.
All right. Thank you, Rebecca, Dr. Ampatia. Thanks, everyone, for having me today. I've been kind of eavesdropping on these echoes for a little bit now. I was really grateful to be able to get connected with them and start coming as I was able. So yeah, today I was invited to talk about this work that we've been doing over the last couple of years, and some of you are aware of it. I've worked with some of you, and others I've just met with and discussed it. But I want to talk about what we've been doing, and I hope some of it is educational. I think maybe I've leaned towards more of a reporting of what we've been doing and where we're going. But there are some parts that I think maybe would speak to you. I know a lot of folks in this echo spend time, with people in Tennessee who are using drugs and coming to the programs to get syringes or otherwise interacting with folks. And so you have a lot of sort of one-on-one time with people, and I think understand, a lot of you probably understand the sort of world of people's understanding and perceptions of how to respond to an overdose. So I think, though, our sort of in-depth look at this and the way we've thought about it and applied it to education, I'm hoping is going to be interesting, and maybe there'll be some parts and pieces that are new for you. So we go to the next slide, please. So we're going to talk about how we used the interviews that we did to develop the training. I want to talk about some of the common overdose response patterns that we saw and how that kind of applied to us developing the training. Then talk about the training itself and how it addresses some of these needs. And then, just a brief summary of our current lessons in the early implementation status. Next slide, please. So we'll start with a little bit of story time about me. My journey in this area started as I was finishing up my program in 2015. My dissertation, I have a degree in epidemiology, so I was encouraged to focus a lot on quantitative work, and so I was interested in these ways that we kind of surveil substance use disorder. Some of you remember back then we were looking at abuse and dependency as our sort of criteria from the DSM. We've moved into the substance use disorder. So I was just looking at the differences in how those the diagnostics and surveillance systems they differ just in how people respond to those questions between rural and urban areas. And when I got out of the program, I stayed at ETSU and was able to do some work with folks at Over Mountain Recovery in Northeast Tennessee on how the behaviors or things that they have going on that contribute to their movement from the way we conceptualize it from this population of folks who are using opioids to the population of folks who have overdosed in some capacity. And so really got into these nuts and bolts sort of things like dealer relationships and frequency and dosing and all these things. And that led to this idea of, understanding how people protect themselves from overdose at the point of use. And so we did some work in Southwest Virginia, interviewing people at some syringe programs there. We actually just recently published on this, and we ended up identifying something like 68 or 69 individual behaviors that folks engage in to protect themselves in different sort of clusters, formulations. They're not just mutually exclusive. And the article that we published, I think, is, our intention was to highlight this behavior to kind of counter the discussion around, the idea that people who are using these substances don't care about their safety. And I think that it's an important sort of contribution to that counter discussion. And then we were contracted to work with TDH and to look at how the population of people who use drugs in Tennessee are engaging with service systems. So treatment, their engagement with EMS, healthcare, social services, mental health, and all these things. And we're working on the summary of this for publication. And the idea is that we can see that access to services, meaning if they're available, that doesn't always equate to true access to services for lots of different reasons: transportation, cost, administrative things, obviously stigma, these kinds of things. And so, in 2023, after coming off of that study, we had heard a lot about xylazine. Obviously, it was a big topic of discussion, had been for a couple of years. And so, the OAC funding came through, and we thought that it would be important to kind of understand what people know about xylazine, how that relates to overdose, and how they respond to overdose, and that we could build some education based on like building true understanding of the community in Tennessee that would be targeted and beneficial. Next slide, please. And so, just you can see here just the emerging trends briefs as motivation for this work. And we proposed to do a community assessment. Since getting out of my really quantitative based program, I've really spent a lot of time just doing everything I can to talk to this community. I like to sit in front of them and give folks the opportunity to tell their story. And I find that the things we learn are much more in depth than what we get from the numbers. And so that's really what I'm about these days. And so, if I propose something, I'm going to start with interviews if I can, or I'll end with interviews, or whatever it is. There's going to be a qualitative component to it so I can get the opportunity to work directly with folks. And so that's what we proposed. We would use this information to build a program, and then we would implement it and evaluate it. Next slide, please. So the assessment itself, and I worked with some of you maybe on the call here. We ended up doing, this is an ask that I'm aware of being burdensome to a lot of folks in harm reduction, and this is one of the things, like, I don't know that I would recommend that people that I work with that want to do this kind of research, that they try to do what we did, because I know that there's just a lot of folks trying to come into syringe programs and understand the population, and it can be burdensome. And I would say at this point, I'm pretty thankful I feel like we're giving something back from this work. So we did struggle with engagement just because it's a hard sell, and we're taking folks' time, and people need to be protective of their populations because job one is serving the community and delivering the harm reduction services. But this is what we did. We did get 40 interviews of folks who were 18 and up reporting use in the past 12 months. Interviews wound up being 10 to 30 minutes. We had a cash incentive. So we do cash incentives unless, absolutely forbidden to do it. That's we try to avoid using gift cards or anything like that. It's just I think it's a much more respectful and actually more valuable incentive. And these are the things that we focused on in the interviews. We also did some focus groups with harm reduction staff to understand feasibility. So we wanted to know, like, this is what we're thinking about doing. Is this, what do you guys think? And I think there was a fair amount of reticence from folks that we talked to in the focus groups about it being feasible, because we wanted to do a long training. And I know that everyone working in these programs, you guys are doing sort of more informal, like case by case as people, if you had time to talk to them, like you're getting some training conversations in, and that's really important. And we're obviously wanting to do something different that may or may not work. And so in doing these interviews, we learned that. We also learned from the specific people, clients of the syringe programs, that these folks have critical expertise. They know what they're doing. Some don't. It's a wide range, but a lot of folks do have a lot of expertise in responding to overdose. And that we did need to be doing hands-on training. So we felt that demonstration, simulation, that kind of thing was important. The harm reduction spaces are the right setting because of the trust that's built there, the comfort that these folks have in those settings, the relationships that you all have built. We should certainly validate the community knowledge. The homebrew methods, I use this word a couple times in the presentation here. I'm referring to, ice in the pants, buckets of water, shower, these things that we need to talk about those things. And I'll sort of get into how we handle that. Recognizing that overdose is traumatic. This is kind of baseline for our work in the training, is really being transparent about the difficulties of this process, creating kind of a discussion area that's safe, that everybody can sort of offer what their experiences and have questions and all these things, and really recognizing the difficulty and the trauma that's behind some of it. And then obviously we have to address the changing drug market. We did this kind of in analyzing the data. We have some profiles that I think are worthwhile. These are not mutually exclusive. People sort of, have, this is like a Venn diagram you can imagine, but there's the structured step-by-step approach, the naloxone first, the rescue breath or airway CPR first, the hybrid model, and then there's the folks that are, help or immediately go into help seeking and feel overwhelmed. So we can talk about some of these a little bit more in depth. Go to the next slide, please. So with the structured approach, we've got folks that are just really going to lay out, I'm going to do this, I'm going to do this, I'm going to do this, I'm going to do this. Have a very clear and confident kind of reporting of what they, how they go about responding to an overdose. Not a lot of improvisation. And, they're going to describe the order that they're going through. And what we want to do in this group, or folks that sort of have these characteristics or some level of them, is we want to reinforce those perspectives, that confidence. And then we can work towards sort of standardizing. I've found in doing the trainings and talking to people that there's always some little bit to tweak, some little idea, that we can, sort of clarify and streamline the process. But ideally, we would be able to, sort of bring these people into the trainings at some level as peers and help support, just the group as we're going through a kind of a Montessori model. Next slide, please. So one more back. Yep, there we go. So then the naloxone first folks, like these are the people that are like, I'm gonna give them naloxone right off the bat, right? So when we talk to people, one of the things that we did in the interviews that I wish that I had given a sort of figure for is I really wanted to walk people through their overdose response steps. Okay, so you do this, and first you do this, and it required some discussion to get there, so that we could kind of lay out like an idea of what they go through. And there were folks that were like naloxone first, and that was their go-to. Some folks, really experienced a good amount of panic about waiting between doses. That's very common. And so thinking like we could run drills, or the simulation is going to be valuable, and then just sort of emphasizing throughout the training this like, dose, breath support, reassess, redose if needed, and the timing in between doses. Next slide, please. And so then we had folks that, a lot of these individuals that talked about, I'm going to stick with rescue breaths or CPR. They were oftentimes trying to avoid the negative experience of naloxone administration, right? So people going into withdrawal, and so they're like, I'm going to avoid naloxone unless I have to. I'll do the rescue breaths. That was some folks, and those people that said things like that tended to have had training in the past. But we want to make sure that it's clear, when rescue breath is appropriate, when, chest compressions need to be brought in for these folks, to make sure all of that is clear. And we can do that through demonstration of rescue breathing and positioning these things. Next slide, please. So the improvised hybrid response is, there's a lot of, this could include a lot of these sort of homebrew methods. And so, we want to really focus in on, I say things like, I'm not going to tell you this doesn't work. What I will tell you is that rescue breathing works, naloxone works. So let's make sure we're not taking time away from those things to do these other things. They can be supplemental. Let's think of them as supplemental if possible. But I think it's important to respect people's experience, because you cannot tell someone who has seen someone come back from ice in the pants or a bucket of water that it doesn't work. You'll lose people. And so we just, we try to have it be more incorporated into the process if possible. And we do encourage, or we discourage slapping and these things that are more aggressive. Next slide, please. And then we have the folks that just really, responding to overdose is over me. I'm going to call the police right away. I'm going to look for some help right away. And I think this is a valuable perspective if that's, be true to how you're really feeling in the situation. And I think we can maybe give some techniques if these folks find that there's no one to reach out to, and that they can, help provide some breaths and these things in a sort of regimented way if EMS is on the way. Next slide, please. So the reality is that all of this stuff is kind of mixed together, right? Like, I just want to make sure that we're clear, like, these profiles are not exclusive, and, we can't just label people as these things or these things, because next slide, please. Because in the moment, there's lots of things that sort of contextualize and have influences on what people are doing, right? It's like where they're at, what kind of, drug they know is on board, the relationship with folks. And so I think the profiles are valuable to kind of get a sense for like what is out there, and helps us hone in on what we need to do in our trainings. Next slide, please. There are some cross-cutting needs. So obviously the panic and the emotional load is common. And so we need to take a trauma-informed approach. I'll say that naloxone timing is very common to be confused across the population. Lots of different responses as to how long you should wait. The homebrew methods are common, and we need to address that. 911 decision-making and the implications of that, opioid sedative overdose and sort of the implications of that with regard to, our indicator for overdose reversal being breathing, not consciousness. And then, the hands-on peer-led in a trusted space is, I think, really valuable. Next slide, please. Really trying not to take too much time here. So this is, we don't show this to our participants. This is our sort of like mind map. This is how we started thinking about these decision points and how we would want to discuss it and deliver content around it. Really it comes down to, we want to make sure that people are clear when knowing when to respond as if an overdose is occurring. We heard from a lot of people about people administering naloxone when someone is just nodding out, and so we really emphasize, the breathing, the checking of the breathing, and that being the indicator. And then we try to talk about like how long you need to wait between doses, and what you can do in the rescue breathing being something you can do with yourself in that interim. And then knowing when the overdose has been reversed, and the breathing again being that indicator. All of it sort of, geared towards efficacy and the least impact on the recipient as possible, right? So being effective and not overdoing it, so not precipitating that hardcore withdrawal if possible. And there's lots of details as well in here, what you would do if you see someone stop breathing, or what versus what you do if you come upon someone and you don't know how long they have not been breathing. So next slide, please. So we developed the training, and basically it's a small group training that occurs during service hours at syringe programs with clients of syringe programs. Now we have actually trained a couple of volunteers because I want anybody who wants to participate to participate. We try to keep it up to 4 per session, but we will flex that. We have when we go, we will tend to do 3 to 4 trainings during those sessions or during service hours. And so when it gets to that last, training of the day, people want to get in. And so we've, loosened up the numbers a little bit. So we do a pre-survey. We do 30 minutes of training and simulation. We cover overdose recognition, naloxone use, rescue breathing, mixed opioid sedative overdose, 911 engagement, and post-overdose care. So we do have a hands-on practice. We have some CPR dummies or mannequins that we bring in, and we have the intranasal naloxone trainers. We have 2 co-facilitators. The fellow that I teach with he's a peer specialist. And then we do a post-survey at the end. We consent people for about 45 to 60 minutes. I'll say that we're pretty close to about 45 minutes. This is a lot of time. Most of the time, or most of what feels like the unnecessary time, is the pre and post survey. We're going to be proposing this training in South Carolina because one of my colleagues on this project is at Furman, and we're going to do something different because the surveys are just onerous, and we could really knock out some trainings if we didn't have those. I tell people now when I do the trainings, like we give you your incentive to do the surveys, the trainings. People really are engaged with it, so I think it's the surveys that take time and are difficult. These are the impacts that I think we've kind of covered that. We have done 3 trainings, 51 participants at 2 different harm reduction programs. So we've been to one place twice. Next slide, please. So kind of what has come out so far, we've had a fairly even gender distribution. Our age distribution is pretty, it's obviously normally distributed there. We've got a lot of folks towards that 35 to 54 range. Next slide, please. This one is interesting. If you look at the top, along the bottom there, those bars are the percentage of folks reporting how many times they have responded to an overdose. And so, there was 20% of folks said they hadn't ever. Most, though, were in the 2 to 10 times, the 11, 20, a good amount there, and then and some folks that were, real veterans of this experience. Most people had not ever received any formal training. There were some that reported they've been trained on the signs of overdose, CPR, rescue breath, and how to administer naloxone. I was a little surprised that the administering naloxone training wasn't higher. I guess we're not doing that as much, or it's not required anymore. Next slide, please. So comparing the pre and post surveys, just a brief treatment of what we're seeing. If the xylazine knowledge did go up, so we were teaching some folks a little bit about xylazine. The overdose knowledge, like how to identify an overdose, that did seem to go up with the training. The attitudes towards overdose and the concerns about overdose, those 2 are kind of 2 sides of the same coin. Attitudes being like, I know what to do, I can do this, and concerns is I would be nervous to do this. And so attitudes or comfort with responding went up, and concerns went down. Next slide, please. So we are reaching a group of people that are, the intention is to reach people who are most likely to be present during an overdose. This is the population that I want to be working with, if I can. But we're also open. We're going to be expanding it, and I think ultimately we'll be doing this for all kinds of folks. So it's not a blank slate group. This is not a group that doesn't have any skills. So I think it does seem that we are adding some knowledge and awareness, sharpening some of the skills, and then maybe organizing the knowledge. That's what I feel like my experience of doing the trainings is that we're kind of just like, rounding the edges on some of the stuff that folks already know. And we have seen some of this stuff move. I think, really the pre and post survey model is not very scientific, and I don't really put a lot of stock in those data. It's kind of what we need to do for our funding and to really give some clear indication of what we're seeing. But for me, I think what I have experienced is that we really are connecting with people, and that we are fostering this, increased self-efficacy and agency in this population. I do get a lot of appreciation from folks who participate. And I, walk away feeling like, everybody that participated felt supported and appreciative of the knowledge and the things we're trying to do. So that's really the value for me in doing it. And I think I hope in the future we'll be able to really maybe figure out some ways to illustrate impact. Next slide, please. So what we're doing now, we're going to do more trainings. That's what we really hope. We're doing these for the next 3 months. I think Dr. Amatia will be sending out the sort of announcement of the training that she's already sent out once. I think we're going to do it again. We're wrapping up at the end of June, and we'll be reporting out. Like I said, we're also about to apply to do this in South Carolina. We have lots of really interesting publications. One thing we're doing is a discourse analysis of the data, which is really looking at how people talk about these things. And it's a technique that I think really gives voice to the population that you're working with. And it's something that's not really as widely used in public health, which is my area. So we're excited to do that. And then we're looking for funding to expand and turn TN-Core into AppCore. So the goal is to build a coalition of folks from multiple states in Southern Appalachia and work directly with those folks to, sort of go back to the drawing board with the trainings, take what we've learned and improve on it, and then do some implementation and piloting. And I think, team, the training that we're doing now is potentially laying this foundation for us to do some real, good work in Appalachia and harm reduction settings. Next slide, please. Okay, I don't think I went too long. I'm looking at it. I think I'm hoping there's just enough time for everybody to have the discussion they want to have. So any questions?
Thank you, Dr. Brooks. Yes, we will open up to questions, and we will still have time for the discussion too. So you can, unmute and ask your question, or put it in the chat, or you can also use Menti, which is an anonymous way to also ask your questions. So please ask questions for Dr. Brooks, and we would love to make sure we answer those.
I said it all.
How do you think high-dose products are impacting response?
Okay. Yeah, I think that, well, so first of all, I think the community, like bystander utilization of naloxone rate, where people are using using Narcan before EMS arrives, those data are, I think they're not great. I think there's so much panic that goes on that the number of doses that are required And this and the narrative of fentanyl requiring more dosing than heroin did. I just don't think that those data are very clear at all, and I don't think are supportive of that necessarily, because whenever I talk to people, anybody who I talk to, and this is not like population-wide survey data, but anybody I've talked to who reports something like having to give 6 or 7 doses of naloxone, you dig into that experience, and you have conversation with them, and they don't necessarily know how long you're supposed to wait in between doses, and there's just a lot of real stress around it. So the high dosing stuff, the market is responding to that, and it's really sort of a lack of good science, I think, behind it. I think that most of the people I talk to are in programs here. All of them are in programs here in Tennessee. And so I know some of the programs have the 8 milligrams, maybe all of them do. But I think that, the high dosing stuff is the people that I talk to that don't feel good about naloxone. I think that's a lot of where it comes from, is their experience of having been given a high dose or lots of multiple doses. So I would kind of put the high dose kind of on the same plane as, or the same row as, having been given a bunch of doses, and the experience of that being really rough. I don't know that I answered your question. Maybe you could clarify a little bit more, but I think that for my money, the high dosing, the high dosing and the high number of doses contributes to avoidance. And so this whole process that we're going through of trying to encourage people to not use alone, it's that counteracts that, because people are not going to want to get a high around somebody who may send them into hardcore withdrawal if they nod out.
Thanks, Dr. Brooks. Yeah, there's been a few studies too. Michigan did a study. We're looking for the resource. We'll get that into the chat too, and on the iEcho platform, that really talks about how people, feel after experiencing high dose naloxone. And there's been lots of research to show that it can lead to certain complications as well. And then also there has been studies to show that higher dose is not any more effective than lower dose. And I think that's really important. So weighing that it's not necessarily more effective to go higher, but it does have negative impacts, especially for people who have been using opioids for a long time as well and have that in their system. And there's some great resources in the chat too, and we'll make sure to get those on the iEcho platform. And then, Bo, I wanted to give you an opportunity if you wanted to talk about your comment as well in the chat about the number of MU receptors.
Yeah, sure. So our bodies have a certain amount of mu receptors, which is what the opiates are actually attaching to. And if enough are attached, that can cause respiratory depression or even lead to respiratory failure, which is what we see presented as a overdose. And so giving a dose of naloxone knocks all of the opiates off of those mu receptors because it mimics how they attach. And so if we're just giving tons and tons of naloxone, there's only a certain amount of mu receptors that the naloxone can attach to. So then you have all of this medication in the person's system that's like not really able to attach to anything, and it's causing these withdrawal symptoms and making folks super sick. And in some cases can be even worse than not having enough naloxone. It's incredibly rare, just prefacing this story by saying that, incredibly rare to have like a pulmonary embolism or something from too much naloxone, but I have seen it happen one time. And so really making sure that we're not encouraging folks to just like wait 3 and 5 minutes and then give another dose and just keep doing that and doing that and doing that, where we could be saying, support their respiratory drive and provide rescue breathing, because giving more medication is antithetical to the work we're doing and is also just not evidence-based. It's not based in science. And that is my tangent.
Thanks, Bo. Awesome, great. Any other questions? Okay, first, please give a round of applause to our speaker, Dr. Brooks, for being here today. We appreciate you and your work with overdose response. And thank you for our questions. And we're going to end the recording and move into